What I'm covering during this ASCO 2020, very special one, is discussing 4 important abstracts that are oral presentation during this ASCO. 2 of them actually raise a strategy question. It's the strategy for patients who receive treatment for metastatic renal cell carcinoma, in which we would like to try to de-escalate a combination in first line, meaning that instead of starting with upfront nivolumab plus ipilimumab, the purpose of this study was to start with single agent nivolumab, then add ipilimumab only in patients who were not having partial response with single agent nivolumab. And so these 2 studies are named the Omnivore study presented by Dr. Raina McKay and the HCRN study presented by Dr. Atkins. The take-home message from these 2 studies are in line with the previous report of the Titan RCC study presented last ESMO. That is basically single-agent nivolumab in first line provide a response rate of about 30%. When adding 4 cycles of ipilimumab in patients who don't reach partial response, you add about 10 to 15% of objective response, meaning that you are able to rescue and induce a response in 10 to 15% of the patient. I think these data are very important because it informs our strategy. We would like to be able to select those patients that don't require upfront combination. However, because this rescue is in the range of, as I said, 10 to 15, around 12, 13, depending on the trial, my feeling is that we are not there yet in terms of de-escalation, and we are looking forward having more data, maybe on patient selection, using either pathological specificity or biological molecular specificity in the long run to be able to select those patients for which we could start with single agent nivolumab. So for the moment, don't change your practice. And in patients that have intermediate and poor, the standard of care is combination strategy, either nivolumab plus ipilimumab or a combination of VEGF TKI plus PD-1 or PD-L1 inhibition. The second 2 abstracts are covering new combination. And actually, the first one is fraction study. It's a study presented by Dr. Choueiri, where nivolumab plus ipilimumab, so the same combination that we know, was used in 2nd, 3rd line or beyond in patients who were previously pretreated both by a PD-1 inhibitor, and mostly nivolumab actually, or with a VEGF TKI inhibitor. And here again, the combination of nivolumab plus ipilimumab in patients who previously failed PD-1 or PD-L1 inhibition, as well as VEGF TKI inhibition, is around 15%. So these are very consistent data across fraction study presented by Dr. Choueiri, as well as the 2 previous ones I've mentioned. 4th and last study was the lenvatinib plus pembrolizumab combination. It's an expanded phase 2. Previous report on 30 patients were presented last ESMO, but now Dr. Lee from MSKCC presented on the overall cohort, more than 100 patients who received this regimen. And what is very interesting here is that response rate in those patients that were previously treated, meaning the vast majority of those patients had prior TKI, but all of them also had prior PD-1 or PD-L1 inhibition. And here, the response rate is in the range of 52%, so very high. Actually, according to Immune Resist, it's actually 55%, and it's very consistent, irrespective of the prior line received. We have this about 50% response rate, including in patients who failed prior nivolumab plus ipilimumab or VEGF TKI plus immune checkpoint inhibitor. So a very strong combination here in 2nd, 3rd line or beyond. We expect phase 3 data in first line through the CLEAR study with regard to this regimen of pembrolizumab plus lenvatinib. So overall, these presentations were about fine-tuning our treatment strategy in first line and sequencing our treatment with new data of combination in 2nd line or beyond.